Hi guys, this is Dr. Abbasi from Blood Talks. Today I'll share with you a very nice presentation, and this is one of the slides I love. And I've taken this slide from Veteran Clinic's website just to declare. And I would explain to you here one of the basics, physiology and pathophysiology of how platelets, 1 Willebrand, fibrinogen, the glycoproteins work in combination to have this whole thing working. And this concept will clear a lot of things in your mind and will make it easier for you to understand qualitative platelet disorders, von Willebrand disease, dysfibrinogenemia, hypofibrinogenemia, and what are the problems going on here. So if you look at this image, so first of all you have to recognize certain factors that are present here. So if you see number one, this one in the yellow, you have a platelet, and on each platelet you have two glycoproteins. One, if you see in this one with the green, this one is the green thingy, it's glycoprotein 1b, and the other one with the blue thing, which you see here also, it's a glycoprotein 2b3a complex. So there are two different glycoproteins on every platelet which has different functions. And then you have these three blue dots here that are actually fibrinogens, and then you have these green pillar-like structures here which are actually 1 Willebrand factor, and then you have the subendothelium here. These are the important players in the game. So what happens now, let me just remove this. So what's happening here is each platelet is attached to another platelet. So this is one platelet and this is other platelet, and they're attached to each other via fibrinogen. Okay, and this fibrinogen is attached to both the platelets through this glycoprotein 2b3a complex. So what will happen is, if there is any problem either in the fibrinogen, which is like dysfibrinogenemia, hypofibrinogenemia, or there is a problem in the glycoprotein 2b3a complex, you will have a problem in this platelet aggregating with the other platelets. So when the platelet to platelets attach, this is called aggregation, and when you have the platelet attached to the endothelium, it's known as adhesion. So there will be two types of defects with platelets: either it's aggregation or either it's adhesion. Number one, this is very important. Then if you see the next step, these platelets will attach to the endothelium here with the help of 1 Willebrand factors, which are pillar-like structures here, through glycoprotein 1b. If you see it here, glycoprotein 1b, there is present here. It's attaching the platelet with the subendothelium via the 1 Willebrand. So if you have any problem in glycoprotein 1b or the 1 Willebrand factor, you will have a problem in the platelets adhesing to the subendothelium, which is technically an adhesion defect. So if you have a question in exam saying what is the differential, or somebody asks you what is the differential for von Willebrand disease, is Bernard-Solier, which is actually glycoprotein 1b defect. Because of that, you will not have proper adhesion. So that's one of the differentials. Likewise, when you go to the other platelet to platelet aggregation, so either there is a defect in glycoprotein 2b3a complex, or there is a defect in fibrinogen, both of them will be differential. So when you have this complex deficiency, you call it Glanzmann thrombasthenia. And when you have a problem in glycoprotein 1b, you call it Bernard-Solier. So let me just clear it for you. Okay, so either of these two defects, or von Willebrand deficiency or fibrinogen dysfibrinogemia, these are the things that could make you confused, but I think I've tried to explain it as I've made it as easy as possible for you guys. Just one more thing, always remember, just an additional thing, that when you have a problem with the GP2B3A complex, and we call it Glanzmann thrombasthenia, in these patients the platelets will actually not be low, so it's just a qualitative defect, and you will have normal platelet count, but the patient will present to you with bleeding. Likewise will happen when the patients will have dysfibrinogemia, for example. But in the other case, when you have a glycoprotein 1b deficiency, which is what we call Bernard-Solier syndrome, the problem is that you will have large platelets. These platelets will be very large in size when you see on the peripheral film, and they will be lesser in number. So when you do a CBC, the platelets will be low, like maybe 75, 80. They're not really very low, but generally low, mild to moderate deficiency. Plus, you will have a qualitative problem that these platelets are not working due to this specific mechanism, because the platelets are unable to attach to each other due to the deficiency, in the Bernard-Solier, due to the deficiency in the glycoprotein 1b not adhesing to the endothelium. This is in the case of Bernard-Solier. And in the case of Glanzmann thrombocythemia, your platelet to platelet aggregation, it becomes a problem. So I hope that makes sense, and you guys will enjoy this session. I would really ask you to like, subscribe my YouTube channel, and also my Twitter X account, which is @Abbasi, ABBASI MUQTADIR. Thank you so much. Bye bye.